right, let's get started again. So first of all, you all are amazing because it's the fourth or the fourth hour of our time together, and it's time for lunch. You all are still awake here, which I really grateful for. You students on what they're doing. You all are amazing. So thank you. If you haven't stood up at the break, please do so now because around third base and headed home. So I realized that mid-afternoon on a Saturday after we've all had lunch and sitting together is a challenging time. So we'll keep moving in this hour. If you have a handout, I'm going to read the case on the front. Don't look at the back yet. We'll get to that shortly. Also, before I start, I just want to say, thinking about my institutional affiliations here, I didn't say this earlier, but just really for disclosure and transparency, which you'll see if you look up my name. I'm a psychiatrist at the medical school at Duke. I also teach at the divinity school at Duke, and I'm trained with theologian. This is a pluralistic group, so I'm not making no presumption that none of my talks are specifically about religion or theology, but I did mention that I studied it. And we have some programs at Duke that, if you have an interest in connecting the world of healthcare and specifically theology and Christian faith, if that's something that's of interest to you, we have Jordan was breaking into Chicago was studied with us, and we have a set of programs for either folks that are taking a gap year after undergrad or are taking time in the midst of health professions training, like in third year medical school, for example, to come and study with us at the Divinity School of Duke. We also have, for all of you, we have like a really great medical school-based bioethics center that does a lot of work. Not quite the McLean Center, but it's a lot there. So if any of you want to talk about opportunities for study at Duke in any capacity, just let me know. I'm happy to talk about that. And I did bring a few flyers for our divinity school-based programs if you're interested in that, if that's of interest to you. Also, I have a lot of fear, actually probably a well-founded fear that I'm not going to be able to get through everything that I'd hope to talk about in this 50-minute session. And so we'll make sure we get that on time. But I'll say afterward, after 3:15, if any of you want to talk individually about anything I've said today or about the topics of this talk, because I'm aware that we're trying to pack a lot into your time today. So with that, let's start with reading this case. This is kind of a long case, but if you don't like long cases, then don't become a psychiatrist. So that's and this is it's a fictionalized. It's a case that I've changed some identifying details, but it's closely based on a recent experience that I had interviewing a patient in my outpatient psychiatric clinic. So let's start with this. Mr. C is a 29-year-old man who presented to a walk-in VA mental health clinic requesting medication, evaluation, and treatment for bipolar disorder. He says that he has recently experienced rapid and strong swings of emotion, ranging from sadness and depression to impulsive energy and anger. Although it's been over a year since he received mental health treatment, he says that things came to a crisis the previous weekend after he discovered a stream of texts between his wife and one of his wife's male coworkers. The text stream led him to believe that his wife was cheating on him. Upon seeing the text, he felt ashamed, empty, and angry. He attempted to wrest the phone from his wife and scratched her arm and struggled. His wife called the police. When the police arrived, they pointed a gun at Mr. C and he ran into a room where their infant daughter was sleeping. He's now facing criminal charges for assault on a female and resisting arrest and seeking to restart medication. He describes intense waves of negative emotion that often accompany perceived slights and frustrations in his relationships. He's been sleeping 3 to 4 hours a night. He feels revved up and exhausted at the same time. He feels that his thoughts are always racing. He finds it difficult to concentrate on anything, but he constantly feels distracted. He's been eating at erratic times, but describes a good appetite. He does not have any current thoughts about or plans for suicide. He drinks 3 to 4 beers once or twice per month, mostly socially. He's not using cannabis, cocaine, opioids, nicotine, or other substances. He endorses hearing voices telling him that he's no good and he's not deserve to be alive. When asked about his mental health history, he says that he first experienced intense swings of anger and emotion soon after his first marriage at age 18 in the context of arguments with his then wife. He has subsequently seen several therapists and psychiatrists during and after his military service. In the Marines, he was diagnosed with depression, and he was more recently diagnosed with bipolar disorder and PTSD. He's been prescribed several medications in the past, and this has been here, venlafaxine, sertraline, and trazodone, but is discontinued all due to sedation and or sexual side effects. He's never participated in structured individual or group psychotherapy. Describing his early history, he initially says that his childhood home was good, but then clarifies that his father would drink too much, and when drunk would be violent with his mother, his siblings, and family. His first marriage and several other intimate relationships ended in the context of physical violence. And he held doctor, he says, my bipolar gotten bad. What can you do? I want to pause and say, first of all, there's a lot of petty things in this case, and you see here a description of intimate partner violence and reference to childhood physical abuse. And the way that we talk about anything related to trauma, something like this is touches for some of us on very personal experiences. I'll say that I want to honor that today, with detail about those kinds of experiences. And I also want to honor you all as you're thinking and talking to honor that any of the experiences here in the class that any of us could be aware of that. I think this case helps us to bring out what are we doing in the world of medicine and psychiatry specifically. And because you all have been talking about mental health for the course of the year so far, including psychiatrists, it's kind of an hour of thinking about what might some of this focus on narrative, on virtue, on ethics, how might it make a difference in the basic ways that we think about mental health care. And I think also anything that relates to mental health care relates to another kind of health care, because as all of you know, this kind of story can show up anywhere. Show up in a surgeon clinic, show up in a medicine, primary care clinician's clinic. And so this is pretty common consultation in conflict with medicine. So I want you to turn to one or two people around you. First of all, just say, how would you describe the problems that Mr. C is experiencing? And then what treatment approaches would you recommend? I realize that some of you are in medical schools and undergrad, you're not trained in this today, so I'm not asking for like a formal formulation. So I just say what kinds of things do you think would be helpful for treatment as he's presenting? We'll talk about that for about 3 to 5 minutes and I'll go to
What are you?
And so when you're perhaps connected to aspects of cheated,
I was noticing how he comes in requesting treatment for bipolar migraine. He says he got diagnosed with it. I was looking it's bipolar details how much of this do I attribute this to emotional situation, and how much of this is when you're having anger bipolar, which going down either way could be very confusing. I went through it underlined all the things differently. Because I was have to stop and how much of this explained by augmented reality
I think one thing I would see several therapists like higher in the past. Like what is the think about bipolar disorder aside, you know, I think all these things.
Just challenging specifically in psychiatry. I'm not yet like this problem. We're stuck with that and everything that happens but specifically psychiatry when people have gotten diagnosis, whether it's right or wrong, or whether it's helpful for them. It's like what they want. Yeah, it makes it really challenging for my healthcare system to assess any other rather just like, well, they have bipolar disorder, they can try this. We're going to look at some of this a lot. I think that coming into this with some sort of humility, like as a psychiatrist or as a therapist, whenever you're saying this thing, what if this is psychiatrist?
Right, let's come back together.
What is right getting to my
thinking about how much you think about say what the conversation about? How do you answer those questions? London. We were getting involved. So, one right. I think some of the symptoms we were talking about was like the voices, and then some dealing with manic symptoms like those two. If those can for that, it can prevent like further escalation of symptoms. Yeah, it's nothing. Kind of focusing on some of the more distressing experiencing. Good.
So we talked about how these problems are very long term, how
Patterns in relationships and fear.
What they experience and also experience like a sort of like what the person is hard if every rest of
Yeah, that part wasn't fictionalized. This patient told me that this is all of my relationships have been really fine. I was like, and they didn't want that way. That really was so.
One of the things our table discussed was how he comes in asking for evaluation treatment bipolar disorder as he's been diagnosed with this in the past. And, we're taught a lot about anchoring bias in medical school, and how in this case, we see like distractibility, sleeplessness, mood swings within emotions, and I feel like it was easy for me to hear, okay, how many of these things match up with a bipolar diagnosis, but at the same time, how many of them might more so be attributed to this recent interaction that he's had with his wife. And so what's the relationship or overlap or usefulness of this bipolar diagnosis within this particular diagnosis?
Is it maybe a valid diagnosis, but is it true? Is it hopeful?
Yeah.
I love where y'all are going with this. Let's kind of zoom out from this particular case, and we'll come back to it in a little bit. But I want to give you some, since this is a seminar about ideas and big picture stuff. I want to kind of compare and contrast like two different images of mental health care. And I think some of the themes that we talked about in this case it's gonna be evident how this matters on the ground in the care of a patient like Mr. C. So here's a way of thinking that I would submit. I don't know, I've never studied Chicago, so I don't know if this is your experience of medical school or those of you that are doing work in psychology as undergraduates. But I'll say that this was characteristic of some of the ways that I was taught as a medical student and as a psychiatry resident to think about experience. I was never taught it in exactly this way. I wasn't like told that this was the way I was supposed to think, but this was kind of implicitly what I picked up on, which is that when you're in the world of clinical psychiatry, that people come to you with unwanted or disvalued experience and behavior. That's kind of a general way of saying like either people have an experience they don't want, or they're acting in ways that they don't want, or sometimes they're acting in ways that other people don't want, and they ended up coming into clinical care. And I was taught that these unwanted experiences are located within individuals, because people would come to me as patients, as individuals, and their experiences somehow inside of them. And that I was to name these experiences as symptoms, because like that's what they were, and I was actually taught to rename them. So somebody would come in and say, I'm feeling really, really sad. And I would say, or I don't feel motivated, or I don't feel like I have any energy to do things that I enjoy. And I would say, I know what that is. It's called something called anhedonia. It's like a certain symptom that I could kind of assign. And that then I was to kind of gather together symptoms and signs into diagnoses that fit the DSM, Psychiatry's Diagnostic Guidebook. And I was not taught explicitly, but like there's this association between diagnoses and things going on in the brain or neural circuits. And I was taught that if somebody carries a diagnosis, then that provides the capacity for then medications and other treatments to be used for that diagnosis. And so that's basically how I was taught. So it's a way of thinking that I kind of got pretty familiar with. So somebody comes into a clinic, you figure out like what are the symptoms, what's the diagnosis, assign a diagnosis, what are the evidence-based treatments, and then move on. I think this way of thinking is helpful, but it has some limitations. So this is not Mr. C. This is a different person that was talking to a set of qualitative researchers about her experience of taking medication. This is I think one way that some people can react to this way of thinking that may be actually not, show its harm. This is described as a middle-aged African American woman named Bernice. I'm talking to researchers about her experience of medication. She said, I told the doctor I was depressed, and he put me on Prozac, which, as you know, is an antidepressant drug. He put me on more medication when I don't need it. I'm not taking that medication because I was simply depressed, and that was it. The doctor never took time to find out why I was depressed. All he said was, oh, you're depressed. I'm going to give you some medication for that. He never asked me anything. He just wrote the prescription out and gave it to me. Now, if you're not like in healthcare systems, you might say, how could that possibly happen? But I know how it could happen. It's because like the clinician was probably pretty busy, and she was coming to him, and he thought his job was to identify symptoms and to assign a diagnosis, and then to assign him. And it's amazing to me how easy it is as a psychiatrist. You can actually I can see a veteran in my clinic and ask just about symptoms, and I can diagnose something like depression or PTSD, and I can initiate a treatment plan without ever actually asking about the person's story, about like what's been going on in their life. And it's disturbingly easy to do that. And so like, how do we guard against that? Well, I'm going to argue that there's two ways of approaching this. One of which I think is this way of thinking about mental health care as a kind of industrial process, treating people as kinds of machines. And I say this applies to psychiatry, but I think this also could apply to other parts of healthcare too. Let you all be the judge of that. But I want to kind of walk back through what I said a minute ago about how does this show up? How can this happen in the world of mental health care? And I want you to think about your own experiences of mental health care, your experience of hearing people talk about it, of being trained in it, and ask yourself, like, to what extent does this fit or not your experience? So one characteristic is that health problems in general and mental health problems specifically happen inside individuals. This is a way of thinking, and this is a ad that illustrates a point for me. This is a pharmaceutical drug ad that came out in the Journal of the American Medical Association in 1967. You can't read the small text. I'll tell you that. What do you see here in this ad? I know you see something. What do you see? Yeah.
The imagery in the picture makes it look like the woman is behind bars and trapped. And yeah, so and that.
Yeah. So you see, I see a woman. I see a young woman. I see a young white woman. It's interesting how many drug ads for depression and anxiety show young women, especially young white women, in the ads. In here, again, this is 1967. She looks like she's in jail, but the bars of the jail are what? Like a mop and a broom, and there's a tricycle behind. So she's in prison, but the things that are imprisoning her are household implements. So here's what the text says of this ad. It says, you can't set her free. By this would have been written for physicians, not just psychiatrists, but physicians who at that time would have been almost entirely, I mean, the vast majority of physicians would have been men at this time in the 1960s. Said, you can't set her free, but you can help her feel less anxious. You know this woman, she's anxious, tense, irritable. She's felt this way for months. Beset by the seemingly insurmountable problems of raising a young family, confined to the home most of the time, her symptoms reflect a sense of inadequacy and isolation. Your, the physician's, reassurance and guidance may have helped some, but not enough. This medication, TRX, cannot change her environment, of course, but it can help relieve anxiety, tension, agitation, irritability, thus strengthening her ability to cope with day-to-day problems. Eventually, as she regains confidence and composure, your counsel may be all that she needs. Anybody have a thought about that? Do you have thoughts about that way of framing her situation? Yeah. Yeah, it's like a massive set of issues. Yeah. Yeah.
The issue is clearly like a more structural, ingrained social weird.
Yeah. Yeah. Right. Yeah. Yeah. Like you're encouraged to see her in a particular way. Yeah. Yeah.
Irritable, but it's the stuff that is the add also the hope that you probably know how to write. Typically that is a lot of these things that you can follow and elaborate on in connection that there's probably something that is making all these things better, but
Yeah.
that is like you get to those things, sure, but there are also different people about things that
Yeah. It's a great point. So that specifically to that point, at this time in the 1960s, this class of medications, which were benzodiazepines, at that point they called the minor tranquilizers, and were the most commonly prescribed class of medications in the United States. And if you go, I don't know if the Library of Chicago will allow you to open the stacks, but if you could get a volume of JAMA in the 1960s and just flip through it, you'll see tons of ads like this, like similar and selling similar kinds of things. So yeah, like what questions like are not being asked by this ad that maybe ought to be asked? Like what's happening in her life? What's happening in her community? What's happening with her capacity to find her vocation and work outside of her home if that's what she desires. What's happening in her relationships? What's happening in her, and like all of these kinds of things are kind of ruled off limits by the ad, and it basically said like you can't change your environment, but this medication can help reduce symptoms. And I want to just point out, obviously 1960 is different from now, but I want to point out that what's a lot of things have changed since this ad, but what hasn't so much changed is the tendency to want to see problems as happening as symptoms inside people and that's the subject of treatment rather than thinking in a broader ecological way about like what's happening to which this might be a response. A couple other ways of thinking. Another would be, so I mentioned individualism and internalism. Another would be what I call self-symptom dualism. And this is the only other ad I'll show. I'm not trying to sell you medications today, but this is a more up-to-date or more contemporary ad for also a depression, anxiety medicine that is still very commonly prescribed now. Some of you may be taking it. But my focus is not on the medication specifically, but on like, what is this ad encouraging? So this ad is meant to be, it's actually on 3 different pages of a medical journal. It's meant to be read sort of from left to right. So on the left side, what do you see? As to what you saw in the previous ad, what do you see in this ad? Another young white woman, yeah, right, yeah, that's right, yeah.
Social isolation inside alone, looking out, like she's trapped.
Yeah, she's alone. The camera's a little bit off balance, and we see this green frame that tells us like what to see, and specifically, we're to see her as depression. Like literally says "see depression." And if you read the white lettering right under her, the frame says my sadness just won't go away. I don't have the energy to go out with friends. My constant worry is affecting my job. So these are all things that, like, if any of you are saying these things, I would encourage you to talk with somebody about it and get help. These are things that are kind of good to pay attention to. They're also not uncommon things. But what the ad is saying, like, given that she's saying these things, to see her as depression. And then having seen depression, to then, presumably there's a very selective interpretation of how this medication can work for depression. And then on the right hand, like, what do you see in that frame? She's not alone anymore. She's arm wrestling. She's surrounded by people. The colors are brighter. She's happier now. Now, what the ad is wanting you to assume there is that the difference here, to see the difference, came as a result of taking this medication, because you have one to the other. Now, of course, that may not have been the thing that made the difference. It may just be that she found a group of friends that she was connected to. But the difference is really because of the ad. The point I want to make here is that this is often the way that especially the pharmaceutical advertising works, but also the way that clinical psychiatry works sometimes, is that we tend to encourage people to see their experience as something that's in some way kind of outside of themselves. And so we can say things like, it's not me, it's my depression, it's my symptoms, it's my anxiety, and other things. And that can be really helpful for a time to be able to do that. So those of you that have had the experience of being diagnosed with anxiety or OCD or other things, and to be able to say, it's not me, it's this, it can provide a way to decrease shame and self-criticism and blame, and to find a way to kind of go on constructively. But the problem is, what if that experience gets kind of left as it is? If one becomes to see not my experience as something that is this diagnosis that can be worked on, but eventually, like, the self can kind of collapse again into the diagnosis, where illness becomes identity, where like people think of themselves as like depressed or anxious or other things. And so there's this way in which the medical language can kind of take over in some ways. And that's something that often can happen. And along with that, having taken kind of symptoms outside of the self as something to work on, there's often this association between mental health symptoms as happening in the body or in the brain. And I think this is, I'm going to go quickly on this because we're going to run out of time, but I think that that in the world of mental health care, that we're much more attached to the dualism of Rene Descartes than we think that we are. So as you know from your, history of working on philosophy, Descartes, in some ways the father of modern philosophy, he lived from 1596 to 1650. He had this. He was living at a time when early modern science was, or what we now consider early modern science, was just beginning to kind of have its origin. He was thinking about the rise of science. He was actually looking to find ways to kind of, in some ways, protect the human being from being kind of, totalized by mechanistic explanations. And one of the things that he did is he said, how can I gain certain knowledge? And Zach's going to want me to be much more precise on this, but like, how can I'm going to adapt a posture of universal doubt. I can doubt anything in the world except my own existence as a thinking being, because I can't, as a thinking being, doubt my own thinking. So I think, therefore I am. And then he said that because I can still doubt the existence of my body, that my body must be in some ways different from my mind, which is myself, and is an entirely different substance from my mind. And so we get from Descartes' discourse on method this idea that that our minds are one kind of substance, and our bodies, which Descartes understood as space and extension and mechanism, is a different kind of substance. So this is this idea of like this substance dualism that we have, where minds somehow inhabit bodies. And I think it's interesting when we then think about like where then do mental health problems lie. In our culture, we still get kind of caught in that split. And so there's a tendency among some people, including, I just mentioned, I'm pretty active in thinking about theological issues in religious faith communities. Like faith communities, Christian communities especially, can sometimes say like, mental illness, it's not a matter of the body, it's just a matter of what you think or what you believe, or if your soul, if you're depressed, you need to pray more or believe differently. That's one way of being Cartesian in the way that we think about mental health problems like depression, to say it's not in the body. But there's another way of being Cartesian, which is to say that the problem is not actually a matter of ourselves or our minds, it's just a problem of the body. You put it kind of on the other side, and so to speak. And so that's where we can get this idea that like all mental illness is just a problem of the brain. But I think for reasons I'll talk about, I think that can actually get in the way of things. And I'll come to that in just a second. So I mentioned individualism, internalism, splitting symptoms off from the self, assigning mental health problems to the brain alone. But once you've identified something as a problem and as a diagnosis, then you can apply techniques to it. It doesn't really matter. Doesn't matter which clinical trial this is, but it allows you to apply technologies to see what can reduce the symptoms. In this case, a neurosteroid for postpartum depression. And then anything that you can apply, any technology that you can apply, can be bought and sold. So whether that's medications, whether it's devices, whether that's units of time of a clinician doing talk therapy. And so in that ways, you can kind of have this process of a mental health care system that works kind of like an industry, where we have standardized processes, we have evidence-based treatments, we have ways to keep going. But what's the cost of that? So let me say a couple of things, and then we'll come back to Mr. C in just a minute. One cost is found in the article that I think you received as an optional reading by Joseph Davis, who talks about like what's the cost of actually seeing mental illness only as a matter of something that happens in the brain or the body. The subjects in his interview study inhabited what he called the neurobiological imaginary, and that about half of the 80 young adults that he interviewed for his study, after asking them to talk about their experience of depression or anxiety or attention problems, that they assumed that their problems were basically problems with their brains or of their neural circuits or their bodies. What that did is that allowed them to see their experiences not really about anything, they just were things that were happening inside them and to them. The good thing was that tended to distance them from self-blame and self-criticism, like it helped decrease shame, which was a good thing. And I think that's a good thing too. But there were a few like unintended consequences of that way of thinking. One is that most of these young adults were taking medication. When the medication worked, it kind of proved that the problem was biological all along. But the most interesting thing is that he said that the interview participants who were saying that like my problem's due to a chemical imbalance or my problems in my brain, they typically, when asked about their goals for therapy or for treatment, like it wasn't so much to get to know themselves better, it wasn't to deepen self-knowledge, it was to get back to the demands of their lives and work. They wanted to go back to school, they wanted to go back to jobs, they wanted to be able to parent, all the kinds of things that, as you all know, young adults are doing and feel compelled to do. And so what Davis asks is like, what's the cost of that? Like, what's the cost of if we think that mental health care is fundamentally about meeting social demands? Maybe actually we're allowing ourselves to be captivated by a particular by a particular economic order that might actually be pulling us apart. So I'm very conscious of the fact that we're like literally in the shadow of the business school at the University of Chicago, which is a center of free market thinking, and so I don't want to like we're going to get like struck by some bolt of electricity that comes from over there. But there is an increasing critique of like what are the costs of living in a culture that's dominated by the very kind of individualism that in some ways is promoted by free market economics. What are the mental health costs of that? So there's a theologian at Vanderbilt, Bruce Rogers Baum, has written about this, and he says we live in a neoliberal age that where privatization and deregulation and trust in the free market, it means that competition and inequality have become core principles of our lives. Like they just are we just assume. You all assume that when you're applying to college, when you're applying to med school, when you're applying to residency, like we're all like in this place of like being kind of individual firms, so to speak, like having to kind of market ourselves. He says every individual becomes an entrepreneur, managing and marketing the self as personal enterprise and investment. And so, well, what's the cost of that? Well, Rogers Vaughan, quoting a different theorist, says maybe depression is just how neoliberalism feels. Maybe when people constantly feel like they're always having to market themselves, when they're feeling disconnected, when they're feeling pressure to produce and to consume and to perform, maybe we start to feel like anxious and we start to feel depressed. And it's a response to a broader cultural order that we live in. So then you can get into a catch-22. So if this is the case, we have a full weekend-long conversation on this, but if it's the case that part of the problem with depression and anxiety, especially in our culture, is that people feel stretched and disconnected, and or counterproductive or underproductive. And if then that drives people like Chicago students to mental health treatment, and if the whole function then of the mental health treatment is to try to get people back to where they can produce and consume in a particular economic order and community, then it may be that the treatment is actually just in some ways like legitimizing and perpetuating the problem. Like you end up like feeding people back into the very cultural system that actually created some of the problems to begin with. So when we think about like why is it that we're experiencing in young adults, for example, like dramatically increasing rates of anxiety and depression, it may not be just that we don't have adequate mental health care services, although those services are important, but it also has to do with like how do we live together? What is it that how do we live together as human beings? So this is where we get, I think, the need for a different model, a different way of thinking about healthcare that also leads to a different way of thinking about being human, that makes clear that we're not machines and we're not like just like things to be treated as industrial products, but we actually are living organisms. And this helps to tie in what you've heard from both me and Dr. Kaljian and throughout this year, the importance of story, the importance of community, the importance of history, the importance of understanding ourselves. So let me just give you three like anchors, and this is on the back of that case description. You can follow along. Three things that I use in my mental health care to try to get away from this way of thinking about human beings as machines or as care as an industrial process that helps me to begin to anchor, like, what am I doing when I'm walking with patients? And to me, the overarching image that I use is that of the human as a wayfarer, as someone who's on a journey. That we're all on journeys of various sorts. You all have places that you want to go. Maybe you want to go just out of here right now, but you have places in your lives that you're interested in going to, and we walk alongside each other as those who are on a journey. And clinicians are also wayfarers. So three things that I think are important. The first is relationship and community. This kind of gets really to this core of what I talked about this morning. But this is the last image that I'll show like this. But and since we're about to run out of time, I'll kind of go through this. I don't know how many of you can see a young woman who's kind of looking up and to the right. I don't know how many of you can see an older woman who's kind of looking to my right, to your left. If you can't see both, the necklace of the young woman is the mouth of the older woman. You've probably seen images like this before. How many of you can see both the young woman and the old woman at exactly the same time? Anybody? I've done support groups, and there's always a few hands. You all have brains that I don't have. So like when I look at this, my brain, it's a gestalt image. My brain can toggle between the two, but it can either see the young woman or the older woman, but not both at the same time. This is an analogy for two ways of thinking about mental health problems that I find really important when I'm supervising residents at Duke or when I'm thinking about my own clinical care. One would be what I consider an inside-out approach, and this would be the basic idea that mental health problems start on the inside of a brain or someone's personality, and then they show up in relationships and in community and in way that people engage in their work and life, in culture. And that's the way that I'm kind of taught to think as a psychiatrist. So when somebody comes to me and says, like, I'm a student at the University of Chicago and I'm really struggling in this class and I'm just feeling really kind of, depressed in general. I'm taught to think, my first thought is like, what's happening inside this person that I can then treat? But what if it's actually the reverse? What if the locus of the problem is in unhealthy relationships or in a culture, in a community that isn't working in a way that's contributing to flourishing? This gets to our conversation this morning. Or in a culture that's like polarized and fragmented and there's a lot of things are wrong. Then some of those experiences may be responses to that broader pathology. It might even show up in neural circuits and in the brain, but the brain and the neural circuits aren't the core of the problem. The problem is in the community and in the culture. And that would be more of an outside-in approach. So in other words, what if mental health problems are not problems on the inside that show up in relationship and community and culture, but what if they're primarily problems of relationship and community and culture that then show up in some ways on someone's experience and even in their neurobiology? And I think thinking about which of these models fits, because both of them often fit to some degree, is really helpful in thinking about mental health challenges. I'll skip this, but there's a really interesting book by journalist Johann Hari about what if depression and anxiety in our culture is not just because our genotypes have changed or our brains are broken, but what if it's that we live in a culture that no longer meets our basic psychological needs? And specifically because we feel disconnected from each other and from various other things. I think this is important as clinicians to ask after the 4 Ps that those of you that are in medical school have always been taught. Like, why is the person vulnerable to this problem? But also, like, what's happening that's perpetuating this experience or these symptoms? Why is this person still having this problem? And what's protecting them against in various ways? So one is relationship. The second is what I consider agency. And this gets to how I think virtue is practically helpful. And I'll say more about the virtues in just a few minutes. But agency to me is different from autonomy. Autonomy tends to have this idea of like being our own masters or, directing ourselves. But agency has more to do with, like, as a human being, am I capable of being the kind of originator of my own action, working toward purposes and goals in the world? So the opposite of being an agent is to be a patient, which in this case just means to be acted upon. What does it mean to actually be free to act and to choose toward those things that I perceive to be good? And I think that's what we want for ourselves, but it's also what our patients often want for themselves in the context of mental health treatment. I interviewed for a different project. I interviewed a psychologist at Brown, Jennifer Freeman, who works with kids with OCD, and asked her how she talks to kids and parents about taking medication for OCD. And she says, well, if families are hesitant about medications, I'll say this. I'll say it's like water wings, like floaties that kids use. This is not going to teach you to swim. The cognitive behavior therapy is actually the active treatment for pediatric OCD. But you need something to help keep you afloat while you're learning to do this exposure part of treatment. But then if families are just wanting to take medication and not wanting to do the particular kind of therapy that's most helpful for OCD in kids, she'll say medication is actually not going to change the process. It might abate the symptoms for a while, but what we're trying to change is a whole approach to life. In other words, what she's focusing on is not symptom reduction specifically, but it's like helping people to become agents. Then the last thing I would say, and this ties into what we said with Dr. Kaljan, is that it's really important to focus on stories, like the stories that we bring in as clinicians, the stories that of our patients and of their communities. So let me just read you one excerpt from a paper by a friend of mine, John Swinton, who works on like religious ethics and medication. He interviewed a woman who, a 32-year-old woman with schizophrenia, and she was talking about her experience of taking medication for schizophrenia. She said, one of the things I found difficult was that the psychiatrist would be like, your voices are bad, so we're going to give you medication to get rid of the voices. But I would say, not all the voices are bad. Can we keep the nice ones? So I understand why a lot of people don't take their medication, because it's actually sometimes a lot harder to be without your friends and to be with your enemies as well. It's better to have them all than to have none. And so I think the medical model, I understand what they're trying to do. They're trying to make people normal, but they don't take into account that this is somebody's narrative. These are characters in their narrative. So you can't just, it's like taking away their family, you know? You can't do that and not have any repercussions of that. This woman, she heard voices. She had schizophrenia, but she didn't want to take her medications because she was worried that if the voices were to go away, that she'd miss them, that she'd be lonely. And there's nothing in like evidence-based protocols for treatment of schizophrenia that would account for that kind of situation. You have to listen for stories and have to know people's narratives. So how does virtue matter? So I should have called this both a virtue-based and narrative-based approach to mental health care. But I want to just close by saying that I think virtue is a really helpful way of thinking about this, because I think it gets to like what's the point of virtue? The philosopher Herbert McCabe said that virtues are dispositions to make choices which make you better able to make choices. Like, and that I think is the core of a lot of what we aim for with our patients. But just specifically, if we think about the 4 cardinal virtues, like how might this apply to mental health? Like, well, one of the cardinal virtues is practical wisdom or prudence or phronesis for Aristotle. This would be the disposition to discern the right response in any given situation. And to make a long story short, like practical wisdom has a lot to do with being grounded, with being mindful, with being attentive. So a lot of the ways that mindfulness and mindfulness practices are a key part of current mental health care is actually about the cultivation of practical wisdom. Justice is incredibly important as a kind of disposition for mental health, and I think we can think about like the importance of justice as absolutely central. And Aristotle, despite in some ways, you know, having a limited view of the polis, he did talk in his ethics about justice is regarded as the highest of all virtues, more admirable than morning star and evening star, and it's actually necessary for sustaining any of the other virtues. So again, we can't think individualistically about the virtues or about mental health. Courage, I think, has to do with what does it mean to be someone who can face real challenges, including threats like death, and continue to move forward toward what's good consistently. And so courage is different from like having no fear at all and being kind of, you know, reckless, but it's also different than being kept from being able to move forward toward what's good. So when I work with trauma survivors, like courage is actually central to what it means to live in the aftermath of trauma. And then we get to the virtue of temperance or self-control, which is often like people shy away from that because it seems like kind of moralistic. But self-control for Aristotle and for virtue theory is ultimately about what does it mean to care well for our bodies, and whether our bodies get what they need and that we get what we need without being distracted by sensory things that keep us in a state where we live in an unhealthy way. So it's ultimately not about what we shouldn't do, but rather about what we should do to care for ourselves in a way that allows us to live in a wholehearted way. So I'm almost at the end of my time. I do wonder, well, I'll tell you what, let's actually not unpack this as a group. I'd like you to turn to 1 or 2 other people and think about this case of Mr. C and think about like how would you, in the light of relationship and agency and story, if you were going to think about caring for him, specifically prioritizing those things, like what would you do? Let's do that for just a few minutes, and I'll briefly close this.
I don't know. Or I guess like that. Yeah, that's really fine. Oh, no,
I'm gonna respect our time, and again, I'll stay after 3:15 for any of you want to talk about these issues or this case. We don't have time to have a large group discussion about this. I'll just tell you what I did as a clinician and how I thought about this. We sat together, she and I sat together after that first intake, and I said, I understand that other clinicians have called this bipolar disorder, and I hear a lot of things that are resonant with that. But actually, there's a different diagnosis that we use that I wonder if it might help capture some of your experience. And I talked with them through the concept of borderline personality disorder, and that's something that's often rooted in childhood traumatic experience and is characterized by streams of emotion and difficulty with emotion, especially in the context of relationships. And I said, I wonder if this might be actually a better way to tell the story of what's been going on for you. You've never heard that term before. And for those of you who know that often clinicians avoid talking about it because it's perceived as stigmatizing. I think unfairly so, but sometimes we know. But he actually was like, oh, that's really interesting. I actually think that fits me really well. And then actually called me a week later and said, I've been reading about Gordon Personality where it really fits me. And that gave us the basis for saying, okay, well, if that's the case, then actually the key approach here was not medication,
but it would be particular kinds of therapy. And so first we got involved in the group-based program at the VA for perpetrators of human partner violence. We completed that. He's now awaiting dialectical behavior therapy, which is the kind of gold standard treatment for borderline personality. He's doing something else called problem-solving therapy while he's waiting for that. Basically, he's like working on kind of skills of what does it mean to recognize emotion, what does it mean to understand his ways of engaging in a relationship. And so it's an ongoing process, but kind of got away from talking about medication. I did prescribe like hydroxyzide, I think histamine, we really needed it, but for the most part I didn't prescribe anything, but focused on what does it mean to continue to work on understanding his emotions and especially emotions in relationships as part of the story. And so far so good. So it guess me 6 months, like all right, it's mid-afternoon. I can tell you all are tired. We want to have some time to wrap up. Thank you all so much for being here today. And again, I'm happy to stay afterwards.